Good evening, everyone. On behalf of Concord Biotech, it's my huge pleasure to extend a warm welcome to all the participants. Concord Biotech is a global biotechnology leader in immunosuppressants with strong abilities in the manufacturing of high quality APIs and finished formulations. With a presence in over 70 countries, we remain committed to delivering excellence across key therapeutic areas, including rheumatology, immunology, transplantation, and nephrology, driven by a patient centric approach. It's my privilege today to host the second session of the webinar series of Pharmaco Rheumatology, and it's my extreme honor to introduce our esteemed speaker for the day, Dr. Vish Prakash Tiwari. Very good evening to you, sir.
Thank you. Very good evening. Good evening to all.
Dr. Tiwari, as we already know, he's a DM clinical immunologist and rheumatologist based at Indresh Hospital, Dehradun. And we really, sir, we are very honored to welcome you here. And in
Thank
this, we all know, sir, doctor, we all know that in today's rapidly evolving medical, landscape, the pursuit of knowledge and clinical excellence is very much essential to enhance patient outcomes and also guide the clinicians to stay aligned with the latest evidence-based practices. So, in this context, Dr. Tiwari will be sharing today his expert insights with all of us. So, a very warm welcome to you, sir. And now I just hand over the session to Dr. Tiwari. Thank you, sir. Please proceed.
thank thank you so much. Uh, my name is Dr. Vishwaprakash Tiwari. I am Assistant Professor of Rheumatology in Indresh Hospital. We have started a series on rheumatology. First was the Pharmaco Part 1. In that, I discussed CS DMARDs, conventional synthetic DMARDs. So, in the lecture part 2, now we are covering the other immunosuppressive agents, synthetic agents like mycophenolic acid, azathioprine, cyclophosphamide, and calcineurin inhibitor. So, first one, what is immunosuppressive drug? These drugs have multiple classes that reduces the immune system, mainly targeting through T cell and B cell. So, how T cell and B cell either they functionally suppress the T cell or B cell, or they reduce the number of immune cells. Means either cytotoxic or cytostatic drug. Okay, these two things are different. These drugs do not correlate. These drugs do not correlate with the underlying immune dysregulation of autoimmune disease. Hence, why it's not curative, but it's a disease. It's a disease modifying agents. Okay, chemical role, different roles are there. Any autoimmune disease is there, like a cancer therapy, we have induction, then maintenance. Different drugs, what we are covering today, cyclophosphamide, azathioprine, mycophenolate mofetil, cyclosporin, tacrolimus. And these drugs used not only in rheumatology, various other fields also, like dermatology, nephrology, gastrointestinology, ophthalmology. All these drugs are there. And we have some new drugs also, which we make it here. So let's start how immunosuppressive drugs, traditional immunosuppressive drugs comes. So please focus on this part. This is first antigen presenting cell. Antigen presenting cell can be B cell, macrophage, or dendritic cell. They present the antigen to the T cell through MHC. This is known as signal 1. Okay. Then you need a co-stimulation. Once this first engagement is done, then through CD28 and B71, B72, that is not important for now. That is signal 2. Then third signal is a cytokine signal. So you can say first is an antigen specific activation. Specific antigen chooses the specific cell. Then the co-stimulation, then final the survival signal. So once the survival signal comes, so here we have a naive T cell. Naive T cell means no not active T cell, no autoreactive cells. So once they got the clonal expansion, they forms the effector T cells. That is one. So we have to understand antigen presentation, then co-stimulation, then proliferation, then clonal expansion. This clonal expansion has been done through calcineurin pathway, that is NFAT, which is a transcription factor for the T cell, which actually increases the, here it is wrong written, increases the IL-2 secretion, which leads to the T cell activation. So, simple word, IL, calcineurin, IL-2, then proliferation. Then once the cell goes into the proliferation, it goes into different stages. This the stages leads to the DNA replication and amplification of a nuclear material. So it goes through from G1 to G1S G2 phases. Different phases are there. So you can see simply we can inhibit the calcineurin means T cell activation through calcineurin inhibitor. We can inhibit the cell cycle through mycophenolate mofetil, different phases like S phase, same with azathioprine, same with cyclophosphamide. Our final result is decreased immune response. So this is the over outlay. Outlay how cell got activated, and once the cell got activated, they have to go for the proliferation, amplification. For amplification, they need a raw material of a DNA which should divide or replicate. So signal is there, then replication is there. So we can block the signal through calcineurin. We can block the cell cycle through different agents like azathioprine, mycophenolate mofetil, and cyclophosphamide. So understand this pathway. We will not go in the detail, and that is not necessary for us also. So how the cell divide? We have for the DNA synthesis or RNA synthesis, we have two pathways: the de novo pathway and salvage pathway. De novo pathway is a pathway where we form the DNA from the basic, and salvage pathway is from the some intermediate materials. So, first thing is that we have some ribose sugar. That ribose sugar has to be phosphorylated and converted into the inosine monophosphate. Then inosine monophosphate convert into the guanosine monophosphate. And guanosine monophosphate, it goes under the salvage pathway. As you know, we have purine and pyrimidine. For the purine, we have adenine and guanine. So once you form the guanine monophosphate, it can form the DNA. Okay, so anything which inhibit this GMP pathway, which that can affect the DNA synthesis, even ribonucleotide through RNA synthesis. So this is total. This is a de novo pathway where we have to important कि GMP should be formed to continue the cell cycle in salvage pathway. Salvage pathway is very important for the lymphocyte. Other cells can use the other sorry, de novo pathway is very important for DNA for lymphocyte, and salvage pathway is important for the other cells. So if you inhibit something from here, like last time we read the leflunomide, that is a dihydroorate dehydrogenase, then we can inhibit the other things, inosine monophosphate we will see. So I just want to show you how the cell divide. So we need to form guanosine monophosphate. That is important. So first drug we will see the mycophenolate mofetil. That is very important drug in rheumatology. We use mycophenolate mofetil in different diseases, and now we have a very good results of mycophenolate mofetil with lupus nephritis, and especially it is a miraculous drug in the case of SLE. So let's see how it works and why this is important and why this drug is well tolerated rather than other immunosuppressive drug. And actually this is a immunosuppressive or anti-inflammatory. Let's see. So discovery part. First time in 1893, Italian scientist that Bartolomeo Gossio, he formed this antibiotic from a fungal source. So most of the people know first antibiotic was the penicillin that was made by the Waxman. But technically in 1983, they already make mycophenolate mofetil, which was a technically antibiotic derived from fungus. As you know, in the Latin, we use the word myco for the fungus. That's why the name is mycophenolic acid. Myco word comes from where it derived. It came from its derivation. That's from the fungus. Then through 60s and 90s, then it rediscovered as an immunosuppressive agent. Then in 90s, then initially it was the mycophenolic acid. What was the derived from the fungus was the mycophenolic acid. Problem was that it has very less absorption. So they just modify it with some ester bond and make it mycophenolate mofetil, which was a prodrug, which with very with proper pharmacokinetics, what we need and good absorption. And in 1990s, it was approved in organ transplant. Then from the organ transplant to now we are using it in autoimmune diseases and organ transplant. Okay, so in 1983 it was discovered. It was discovered from the fungus. It was an antibiotic. Okay, so let's see another part. As I told, mycophenolate mofetil is a pro-drug. Actual drug was mycophenolic acid. Problem was with the mycophenolic acid that it was has a very less bioavailability. So we structurally means pharma companies structurally made morphinyl ester in it. Morphinyl ester and lactane ring. Morphinyl ester not increasing the potency, that increases the absorption. So mycophenolate mofetil created from the mycophenolic acid, which was the active component, to increase the absorption. As I told you, it is derived from the fungus Penicillium species. Cellular level, we will see how it will work here. So, as I told you, T cell, this is a T cell or B cell. They are for the DNA synthesis, for the replication, they are using the de novo pathway. In de novo pathway, we need to have a guanosine monophosphate. So, guanosine is made from the inosine through inosine phosphate dehydrogenase enzyme. So, mycophenolate mofetil inhibit the inosine phosphate dehydrogenase enzyme. So, that's why less GMP, that's why less DNA RNA, that's why less B cell activation, that's why less T cell activation. That is one. Second, same drug also inhibit the fibroblast proliferation. That is new. So you should know mycophenolate mofetil inhibits the B cell proliferation, T cell proliferation, and fibroblast proliferation. So you can say in a different autoimmune disease and fibroinflammatory diseases it can use. Okay, so it targets the purine, which pathway? De novo pathway, not salvage pathway, and it inhibits the inosine monophosphate dehydrogenase reversibly. And second thing, inosine monophosphate dehydrogenase, we have two types of the isoform, IMPDH1 and IMPDS2. IMPDS2 is more on the T cell and B cell, less on other cells. That's why mycophenolate mofetil is little bit more specific for the lymphocytes. So this is second point. So you have to remember mycophenolate mofetil is a prodrug. Mycophenolate mofetil inhibits the inosine monophosphate dehydrogenase that is reversible. Which isoform? Inosine monophosphate dehydrogenase type 2. Which cells are targeted? B cell, T cell, other than B cell and T cell, fibroblast, endothelial cell, and vascular smooth muscle cell. So this is the effect on lymphocyte. Then what beyond lymphocyte? As I told, fibroblast, endothelial cell, smooth muscle cells. They also decreases the collagen deposition. And third thing, they decreases the different adhesion molecule, which is important for the immune cells, chemotaxis, not chemotaxis, homing in that organ. So they decreases the inflammation also. So they are not only immunosuppressive drug, they also have anti-inflammatory action. Okay. So let's see the pharmacokinetics. I told you mycophenolate mofetil is a prodrug. So once you take the mycophenolate mofetil in the in the serum and in the liver through esterase enzyme, because it has a ester form, that ester make it mycophenolate mofetil. Through esterase, it converted into its active form that is known as mycophenolic acid. Mycophenolic acid is active form. Okay. Then mycophenolic acid absorb up 90 to 90, 90 up to 95, 96%. It is protein bound up to 99%. Okay. Then mycophenolate mofetil reaches peak level within 1 to 2 hours. Then there is another peak level at around 16 to 24 hours. How it goes? Mycophenolic acid goes to the liver. In liver, it got glucuronidation. So liver make it inactive form, that is MPAG. MPAG can excrete it through kidney, or MPAG can go to the enterohepatic circulation. And enterohepatic circulation, you have GI bacteria which have glucuronidase enzyme. So they recreated mycophenolic acid. So you have two peaks. One, through absorption, mycophenolic acid up to 95% absorption. Then through enterohepatic circulation with the help of gut bacteria, we have second peak. Okay. So you can say from this part when it is 99% protein bound. So when mycophenolate mofetil toxicity can occur, when suppose you have a very severe hypoalbuminemia, albumin is very low. So free mycophenolic acid will increase. Suppose you have gut bacteria, you have used antibiotic like ciprofloxacin, amoxicillin, which kills the gut bacteria. So because they kill the gut bacteria, so glucuronidase enzyme will not work. So second peak is not there, so efficacy will less. So these are the different things. And third thing is that mainly it metabolically active itself in the serum, very less liver involvement, very less kidney involvement. So it's relatively safe in kidney disease and liver disease. That's why it's a choice. Second thing, I told you it is a relatively lymphocyte specific. That is second part. So these two things make it important drug in rheumatology. So this is mycophenolate mofetil. So I told you it is relatively good tolerable, better tolerated. If through enterohepatic circulation it goes into the GIT, it can create the diarrhea. Sometimes mycophenolic acid can create the bone marrow suppression, but they inhibit the B cell and T cell, not specifically platelet or neutrophils. And third thing was there, it is not affected by liver and kidney. But as you know, most of the rheumatological disease occur in the reproductive age group female. So one side effect should know. That is the teratogenicity of mycophenolate mofetil. So mycophenolate mofetil is a because it affect the embryo. Na? So historically in 2001, we confirmed the mycophenolate mofetil embryopathy. Mechanism of action I told mycophenolic acid. They inhibit the inosine monophosphate dehydrogenase. They inhibit the de novo cell. Embryo also uses the de novo pathway. So there are lots of teratogenicity. Pregnancy loss seen up to 50%, major abnormality seen in up to 20 to 25%. Whatever is major abnormalities in this, cleft palate, mycotia, encoltia, ear is not there, some cleft palate, hearing loss, cardiac defect. So these mycophenolate mofetil is an embryopathic drug, teratogenic drug. So whenever patient is on mycophenolate mofetil, we are telling strictly for uh, to avoid the pregnancy to the patient. At least if patient wants pregnancy, then disease should be under control and patient should be without mycophenolate mofetil for at least 3 months. And for the contraceptive methods, I am telling one more thing. Using only condoms is not advisable because we need a double protection because this is very teratogenic drug. So whenever patient is on MMF, you advise patient for using double protection from male side and female side both, not only condoms. Huh? Clinical indication, it's a mycophenolate mofetil. I will just show its use in SLE. Let's see, we will see. Now we are using in proliferative lupus nephritis, the latest class 3, class 4, and even in the class 5 also. This I told you this also affect the fibroblast, so it affect the fibrosis. So it also used in sclerodermal associated ILD. MMF is also mycophenolate mofetil also used in the tried in different vasculitis like autoimmune vasculitis, idiopathic myositis, different ILDs, and for CTD associated PH, not very good role. Huh? So let's see individual indications. This is from the ATS American Chest Society and ACR combined guideline. So you see in for the initial treatment option for the ILD in connective tissue diseases. So see systemic sclerosis, myositis, MCTD, rheumatoid arthritis, Sjogren, in which if you see the first line drug, mycophenolate, 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 mycophenolate. So I am just telling in the CTD ILD also, mycophenolate mofetil you can consider in the first line drug. Rationale could be it's inhibiting the fibroblast also, it inhibiting the collagen deposition also. And there is a study, scleroderma lung study, SLS2. In SLS2, they found mycophenolate mofetil is non-inferior to cyclophosphamide and better tolerated. So for systemic sclerosis ILD, it's strongly recommended as a first line therapy. And SARD, SARD means systemic autoimmune rheumatic disease associated ILD. It can be used as a glucocorticoid sparing agent. So this is for the CTD ILD. Let's then go to the SLE. In SLE, I told you core indication is for proliferative. Proliferative means rapidly progressive glomerulonephritis class 3, class 4. So we can use in class 3, class 4 and even in class 5 also. So now we are using just another point. Now we are using triple therapy in SLE. Okay, like triple therapy in RA you have heard of already. So triple therapy in SLE, that is mycophenolate mofetil, then calcineurin inhibitor, then steroid. That is known as the triple therapy. Okay. It can use in extrarenal manifestations of SLE also, such as hematological manifestation and refractory cutaneous SLE, musculoskeletal diseases, but it's not very good drug for the arthritis. And special, I told you because most commonly it's occur in the female SLE, all those things. So in pregnancy, avoid. And for we have to avoid in the pregnancy. So you can say it's a backbone, kind of a backbone drug in the treatment of lupus nephritis and other parts, other manifestations of SLE. So another part, mycophenolate mofetil in systemic sclerosis. What is the rationale? Again, it inhibits the fibroblast. So different guidelines are recommending MMF as a first line in scleroderma associated ILD. It also found that it reduces the skin thickening that was measured by the Rodnan score, but not very significantly. So skin fibrosis useful, pulmonary arterial hypertension no use, renal crisis we have to avoid uh, because yeah, although in kidney failure it is relatively safe, but if a crisis is there, then we can get the toxicity of a methotrexate. Then so we have to avoid here. Doses, recommended doses is 2 to 3 gram in a day. We are starting with 500 mg BD, then within a week or 2 week, it slightly escalate to 1.5 gram to 2 gram if patient tolerate 2.5 gram to 3 gram. But mostly we are using 2 grams here. So just compare with cyclophosphamide because cyclophosphamide also used in scleroderma associated ILD. So safety wise, it's better. Fertility wise MMF is safe. MMF is bad for teratogenicity, but it doesn't affect the fertility. But cyclophosphamide can have gonadal toxicity also. And long-term therapy, obviously it preferred because of the limitation of the cytotoxicity. So this is in scleroderma. Then mycophenolic acid in the vasculitis. So in the induction, there are different trials in which they compare mycophenolate mofetil with the other drugs. So it can use in induction, it can use in remission, but in remission there is a frequent relapse in ANCA-associated vasculitis. So usually it's not a first-line drug in ANCA-associated vasculitis. Then in other vasculitis, the mycophenolate mofetil can also be used in Takayasu arthritis. Recently, there was a trial known as committed trial trial in which they use a combination of mycophenolate mofetil with methotrexate. So these are the indications of MMF and cutaneous LC, yeah, cutaneous vasculitis, also limited cutaneous vasculitis. Also, we can use mycophenolate mofetil. So this was the about the mycophenolate mofetil. So what is the take-home message? Not used in pregnancy because it's a teratogenic. It's a prodrug. Enzyme is inosine monophosphate dehydrogenase. Which isotype? Type 2 isotype, which is more lymphocyte specific, relatively lesser side effect. It has two peaks. One is through the absorption and another is through the enterohepatic circulation. All these are the important drugs. And right now in scleroderma ILD, it's a first line drug and class 3, class 4 lupus nephritis. It's one of the drug of triple therapy. So come to the cyclophosphamide. Cyclophosphamide is a cytotoxic drug. Mycophenolate mofetil was cytostatic. Why cytostatic? Because that is preventing the formation of guanosine monophosphate, so less DNA, but DNA breakage is not there. But cyclophosphamide is an alkylating agent which can cross-link with the DNA nucleotides. So they breaks the DNA. When the DNA breaks, then through P53, cell can go into apoptosis. So it introduced in 1958 as a cytotoxic drug. It is a still most potent immunosuppressive drug till now. So cyclophosphamide is also a prodrug. It in liver it converted into the its active form, that is a aldophosphamide or phosphoramide or phosphoramide mustard and acrolein. These two things form. So phosphoramide mustard is an active drug which inhibit the lymphocyte or show the immunosuppressive action. But acrolein is a molecule which actually deposited into the bladder and it can cause the hemorrhagic cystitis. So side effect of hemorrhagic cystitis is due to acrolein, and active drug is a phosphoramide mustard and is aldophosphamide. It is used in if any severe disease is there in autoimmune severe disease, there cyclophosphamide can be used. So previously it was the induction of choice in SLE, in ANCA-associated vasculitis. Structure-wise, I told you it's an alkylating agent. As you know, DNA is a deoxyribonucleic acid. It's an acid. It's an alkylating agent. They alkylate with the DNA, forms the cross-linking. Once the cross-linking form, DNA breaks. Once the DNA breaks, cell protective mechanism starts. That is through P53, which leads to the apoptosis of a lymphocyte. That is called as cytotoxicity. So cyclophosphamide is a purely immunosuppressive drug. Hmm. And then the mechanism of action, I told you, same thing. This cross-linking DNA RNA synthesis reduces or damage, then apoptosis. What is the active metabolite? Phosphoramide mustard. What is the side effect? The side effect is through acrolein that leads to the hemorrhagic cystitis. Okay. Uh, and how to prevent the hemorrhagic cystitis? We have a drug that it's called as MESNA, mercaptoethanol disodium, that chelate the acrolein. So while giving the cyclophosphamide, we use the MESNA to prevent the bladder toxicity. What other toxicity can patient can have? Patient can have bone marrow suppression because it affects the DNA. Patient can have severe mucositis, diarrhea. Patient can have gonadal toxicity. Why gonadal toxicity? Because there is an active replication. So gonadal toxicity, myelosuppression, then fertility concern because it prevents the ovulation also, and mesna is used to prevent the bladder toxicity. All these things are there. So these are the bullet points. Cyclophosphamide clinical indication. In clinical indication, I told you cyclophosphamide is till now most potent immunosuppressive drug. So for the SLE, this is used in the class 2, class 4, even in class 5 to Ponticelli regimen, we use in the class 5 also. Any rapidly progressive glomerulonephritis, crescentic glomerulonephritis, that is in SLE. So in LN, it has a role. Extrarenal, in extrarenal, like you are seeing here, NPSLE, suppose a patient has neuropsychiatric complication of SLE like seizures and different things, then we can use cyclophosphamide because these two are the life-threatening condition. Severe systemic vasculitis, any vasculitis and severe systemic vasculitis, we can use cyclophosphamide even in pyoderma gangrenosum. Specific condition in dermatomyositis, polymyositis, if it is refractory, we can use in ILD, even in any kind of ILD. Cyclophosphamide can use in neurobasal disease also. In ANCA vasculitis, it was previously before the rituximab. Now rituximab is a drug of choice, but before that it was the cyclophosphamide. But still, if patient has a ANCA vasculitis which is very rapidly progressive, then we can use cyclophosphamide here also. So these are the different indication of the cyclophosphamide. So crux point is there whenever there is a life organ threatening or life threatening, very severe organ threatening or life threatening autoimmune disease which is very rapidly progressive. So we in that time cyclophosphamide can be used. Side effect, hematological side effect, most common dose limiting side effect. More cyclophosphamide, more bone marrow suppression can be there. It can cause thrombocytopenia, but less prominent. Nadir means highest level of the lymphocyte depletion after giving cyclophosphamide. It is after 1 to 2 weeks and recovery within 21 days. So first time you are giving cyclophosphamide, it is advisable to repeat within 14 days. If leukopenia is there, then we can still use cyclophosphamide in 50% doses. Then bladder toxicity. Acrolein binds to the uroepithelium. It binds to the uroepithelium. It irritates the uroepithelium. It damages the uroepithelium, and it causes the hemorrhagic cystitis. The patient can have hematuria, dysuria, frequency. To prevent this, we are using Mesna. Another thing, patient cyclophosphamide is given through the infusion. So whenever you give the infusion of a cyclophosphamide, advise nurse not to hold urine. Whenever patient is feeling bladder full is there, our whenever patient wants to urinate, he has to or she has to urinate, because this acrolein, the longer the period acrolein will be in the bladder, more chances is the bladder toxicity. That is the reason why oral cyclophosphamide using daily and IV cyclophosphamide and using in the pulse therapy monthly basis. So in oral, bladder toxicity was more. Then again, because of its anti-proliferative action, gonadal toxicity is there. Cyclophosphamide can also have a hyponatremic side effect like SIADA, syndrome of inappropriate ADA secretion. Because cyclophosphamide is a very aggressive immunosuppressive drug, so that can cause opportunistic infections like as pneumocystis jirovecii, fungal infection, and viral infections. Clinical relevance is there whenever you are giving cyclophosphamide. You can use cotrimoxazole. That is a combination of trimethoprim sulfamethoxazole. Long-term use can lead to the hemorrhagic cystitis. That hemorrhagic cystitis can lead to the bladder cancer. Long-term use of cyclophosphamide is irritating your bone marrow. That irritated bone marrow can lead to the different blood cancers like acute myeloid leukemia, myelodysplastic syndrome. Cyclophosphamide is indicated in different ILDs also, but cyclophosphamide also has a pulmonary toxicity. It can cause the early pneumonitis and late fibrosis also. And if you are using a very high dose, cyclophosphamide can lead to the cardiotoxicity. So what I told you, two important side effect to remember, that is gonadal toxicity, hemorrhagic cystitis, hematological complications. Okay, then infections you can connect it through it, but the clinical point is there we can use the sulfamethoxazole here. Uh, then the point now this is complete cyclophosphamide. So important thing about cyclophosphamide, it's an alkylating agent. It's a cytotoxic drug, not a cytostatic drug. It targeted the dividing cells. It is not lymphocyte specific. It can affect the lymphocyte. It can affect the bone marrow. It can affect the GIT cells. It can affect the gonads. Mesna is used to prevent the hemorrhagic cystitis. IV pulse is better than oral therapy because in oral therapy, cumulative toxicity is more. Then azathioprine. Azathioprine is also a prodrug. Okay. So azathioprine, if you see here, prin is here. So prin is homologous to purine. So it converted into 6-mercaptopurine in blood. And this 6-mercaptopurine can go 6-mercaptopurine can converted into the through hypoxanthine oxidase HGRT enzyme 6-thioxanthine. Just remember 6-thioxanthine. 6-thioxanthine can mimic the purine because it's a xanthine. 6-thioxanthine can mimic the purine and can integrate with the DNA, and it can cause the DNA damage and cell death. So azathioprine prodrug 6-mercaptopurine. 6-mercaptopurine is converted into the 6-TNGA, thionucleoside xanthine. TNGA leads to the toxicity. Now, how this active metabolite is inactivated? It's inactivated through two mechanisms. I will explain in a second slide. So this is there. Azathioprine breakdown. Azathioprine breakdown, we can have azathioprine breakdown through two methods, either methylation or oxidation. Methylation is through TPMT. TPMT means thiopurine methyl transferase. Thiopurine is this is thiopurine. Methyl transferase, they transfer methyl into this, then they convert it to the methylated group, which is inactive. Then second part, we can inactivate it through oxidation through xanthine oxidase. It has clinical relevance like this. Azathioprine, 6-mercaptopurine. 6-mercaptopurine can convert it to TGS, thioguanine nucleosides. Thioguanine nucleosides inhibit the T cell. Then through TPMT enzyme, through liver enzymes, it can inactivate it. That's this one. 6-mercaptopurine through oxidation through xanthine oxidase can inactivate it into thiouric acid. Through TPMT, thiopurine methyltransferase, it converted into 6-methyl mercaptopurine. So methyl inactivated compound is liver toxic. Okay. So what is clinical importance? Suppose you are giving xanthine oxidase inhibitor here. So azathioprine will not deactivate it through xanthine oxidase. So more 6-mercaptopurine, more TNG, more anti-proliferative action. So allopurinol, febuxostat, you have to be very careful while giving azathioprine with allopurinol or febuxostat because they inhibit the xanthine oxidase. Then TPMT enzyme. Suppose patient is not having TPMT enzyme. So azathioprine will not convert it into 6-methyl mercaptopurine. So more active form, more immunosuppression. So suppose patient is not having TPMT enzyme. So chances of anti-proliferative action of azathioprine is more. So more myelosuppression. Suppose you have some patients have high TPMT level. So azathioprine level immediately deactivated into 6-methyl mercaptopurine. So efficacy is less, but liver toxicity is more. So be careful about three things. One pathway is activation pathway that is due to HGPRT enzyme. So any patient who have endogenous high HGPRT activity can leads to more active form. Any patients which have HGPRT low level can leads to the less activation form that is there. Then inactivation is through pathway, oxidation pathway or methyl pathway. If oxidation pathway is inhibited, toxicity is more. If methyl pathway is inhibited, toxicity is more. Okay. So this is there. Allopurinol or febuxostat, that is an inhibitor of the xanthine oxidase. So we are giving patient azathioprine and allopurinol together. So they block the xanthine oxidase. So more active form, more marrow suppression. So warning is there. Allopurinol or febuxostat along with the azathioprine can lead to the bone marrow suppression. Then TPMT and NUDT15 enzyme. TPMT is thiopurine methyltransferase. What is it? Gene is associated in the chromosome number 6. We have more than 40 genes for the TPMT enzyme. But important one is the 1A, 1A, 3A, 1A, 1, 3A, and 3A. So we can have, you just see here what alleles are important. Through A, 2, 3A, 3C. And 3 is for the, just let me explain 1 minute. Suppose patient is having normal TPMT level. So you can give azathioprine. Suppose patient is having intermediate TPMT level. So you have to give less azathioprine. Suppose patient is having nil TPMT level, so you have to avoid azathioprine. That is one. But in Indian patient, NUDT15, NUDT NODAT 15, this is they are helping third part this TPMT enzyme. Suppose patient is having NUDT enzyme uh, deficiency, so TPMT level deficiency will occur. So they can lead to the azathioprine toxicity. So one again metabolic pathway azathioprine, 6-mercaptopurine, they are deactivated through TPMT or NUDT5. If TPMT or NUDT5 is not there, then chances of toxicity is more. So one is with allopurinol, one is with this. So how to we are doing the genetic testing of this thiopurine enzyme. So thiopurine enzyme, if it is normal 80 to 90%, then standard dose. If intermediate activity is just 10 to 20%, reduce the dose. If low activity is there up to 1%, then very low dose up to 30%, what is recommended. This is there. And TPMT level we can check in RBC also, but there are two type of testing: genetic testing and this RBC level testing. Azathioprine is inhibiting both because it's a thiopurine. Na? It's inhibit both salvage pathway and de novo pathway. So you can understand it is not lymphocyte specific. So it can have various side effects also. So it can use in rheumatoid arthritis, but not very good drug. For the rheumatoid arthritis, we used in when patient is refractory. Then other autoimmune disease like myopathies, psoriatic arthritis, reactive arthritis, different vasculitis. Suppose patient is not tolerating mycophenolate mofetil, then another option is azathioprine. Why it is more important? Because you can use azathioprine in pregnancy. It is a class D drug. Azathioprine, the neonate, not neonate, the developing fetus, their liver is not fully developed. So you know azathioprine is converted to the 6-mercaptopurine in liver. So suppose liver is not properly working, so 6-mercaptopurine will not properly form. So it is relatively safe in pregnancy. So take home message is there, azathioprine. This is anti-metabolite. Why anti-metabolite? It mimics the purine. Second is it's a prodrug. Third thing, its metabolism is very important. Two deactivation pathway is important: oxidation pathway and methylation pathway. Oxidation pathway has an interaction with allopurinol and febuxostate. Methyl pathway, you have to check TPMT enzyme or gene level before giving azathioprine. Side effect wise, obviously, I told you they are inhibiting, they are anti-proliferative drugs, so they are inhibiting the hematological bone marrow. So different kind of anemias, cytopenias can occur. They can cause liver toxicity, they can cause nausea, vomiting, things also. Azathioprine can also lead to the hypersensitivity reaction within 2 weeks. It's not like immediately. They can also, because they are inhibiting the DNA. Once you inhibit the DNA, then different kind of mutations can occur. Then can leads to the malignancy. Different infections can also occur. Drug interaction, I told you, allopurinol, febuxostat. What other drugs we have to be careful while giving azathioprine, because azathioprine has a strong myelosuppressive action. So other drug which can suppress the bone marrow, we have to avoid cotrimoxazole. It's not good with the azathioprine. As I told you, because in ANCA vasculitis, clotrimazole is also useful. So very careful regarding that. Warfarin, it decreases the anticoagulant effect. So there are different side effects also, almost same. Then come to the calcineurin inhibitor. What is calcineurin? Here. Here, antigen presenting cell give the signal 1, signal 2, signal 3. So once the T cell get activated, so they use the calcineurin. Once the calcineurin forms calcineurin, then calcineurin leads to the N-fat activation. Then N-fat goes to the DNA. They forms the IL-2. IL-2 leads to the DNA replication. Correct, is here when you inhibit the calcineurin. So there is no N-fat dephosphorylation or no N-fat activation. If there is no N-fat activation, there is less IL-2. If there is less IL-2, less T cell activation and less T cell proliferation. So they are T cell specific. Most important, T cell specific. Okay. So cyclosporin, we have different drugs like cyclosporin, tacrolimus, and volcorosporin. Cyclosporin, let's discuss with first. Cyclosporin derived from the fungus. They bind the cyclophilin and create the action. Okay. So if we go like a core concept, antigen presentation, T cell activation, this T cell activation can lead to increased calcium inside intracellular calcium. Intracellular calcium through calcium calmodulin pathway activate the calcineurin. Calcineurin activate the N-fat. N-fat activate the IL-2. Okay. So if you give calcineurin inhibitor, so no N-fat, no IL-2, no T cell proliferation. So it's inhibiting the calcineurin, not DNA. So it's a cytostatic drug. Its effect on the T cell and selectively inhibit the T cell proliferation. And another thing, this same calcineurin, they also destabilize the synaptopodin. What is synaptopodin? Here you are seeing the synaptopodin. Synaptopodin is a part of podocyte. So once you give the calcineurin inhibitor, if less calcineurin is there, then immunological wise less T cell activation. Same thing. If less calcineurin is there is less synaptopodin damage or synaptopodin stabilization is there. So less proteinuria. So you have two actions now: T cell inhibition and anti-proteinuric action. So calcineurin inhibitor have two actions here. Na? One is immunosuppression, one is anti-proteinuric. That's why it's very good drug for the lupus nephritis. Then what happened? Tacrolimus is a nephrotoxic drug. We will see just now after some time. We created a voclosporin. Difference between voclosporin and tacrolimus. It's more stable drug. It's variable. Why tacrolimus is variable, I will tell you. It enhances the podocyte protection. It also enhances the podocyte stabilization. But tacrolimus pharmacokinetics is fluctuating. It's rapidly action. It has a rapid action, rapid proteinuria reduction. It also has antiproteinuric action, but less. It has minimal drug variability. It has more chances of diabetes, reduced diabetes nephrotoxicity, high diabetes nephrotoxicity. One Aurora trial was there. In Aurora trial, what they found कि voclosporin was adding voclosporin to the standard background like mycophenolate mofetin and steroid. There is a 49% complete renal response versus 24% complete renal response in 6 months. Huh? So CNI has two things. Now another thing. This is your pancreas. In pancreas, glucose comes. Once the glucose comes inside the beta cell, in beta cell they form the glycolysis. Through glycolysis, ATP form. ATP form, they block the calcium, a potassium channel. This potassium channel, once you block the potassium channel, intracellular calcium increase. This intracellular calcium through the calcineurin, they form the N fat. N fat goes inside the nucleus of a beta cell and forms insulin. So if you give calcineurin inhibitor, so N fat is in T cell and beta cell, and in neurons and in the heart, but important wise beta cell and T cell. So once you inhibit the N fat, means calcineurin, once you give the calcineurin inhibitor, patient's insulin formation and secretion will be reduced, so patient can have diabetes. So in transplant, it is known as NODAT, new onset diabetes mellitus after transplant, because in transplant they are using tacrolimus. Tacrolimus inhibiting calcineurin. Inhibiting calcineurin leads to the T cell stabilization. So less graft rejection. But same thing, because of inhibition of the calcineurin, there is also less insulin. So patient can develop diabetes. If patient can develop diabetes, then dyslipidemia can also occur. Then hyperuricemia can also occur. So tacrolimus or calcineurin inhibitor, they have a metabolic side effects. Okay. So compare cyclosporin and tacrolimus. Nephrotoxic, nephrotoxic. Clear? Once you involve the kidney, then renin increase. Renin increase, it can lead to the it can raise to the blood pressure and can lead to the hypertension. Hypertension is a side effect. Tacrolimus can cause neurotoxicity also because posterior circulation it's affect. It affects the endothelium of posterior circulation, so that can lead to the stress. They can cause the reduced insulin, so dyslipidemia, hyperglycemia, these are there. Hyperuricemia can also occur. Just two things I want you to remember. Hirsutism and gingival hyperplasia is a side effect of cyclosporin. Here it is not written, but alopecia is a side effect of tacrolimus. So same metabolic side effect of tacrolimus and cyclosporin, but in the case of cyclosporin, more cosmetic side effect like hirsutism and gingival hyperplasia. In the case of tacrolimus, alopecia is a side effect. So you can remember like a tacrolimus can be equivalent to takla, and cyclosporin can leads to the excessive hair growth and gingival hyperplasia around the mouth. Here you can see hirsutism hypertrichosis. Then pharmacokinetics, I didn't discuss with the pharmacokinetics for the rest of the drugs in detail, but this calcineurin inhibitor pharmacokinetics and formulations are important. They are available in capsules form, capsule that is immediate release, extended release, or they are used in the oral suspension form, available in oral suspension. IV formulation is also there, but IV formulation is less useful uh, in rheumatology. So different formulations are there, but here. Therapeutic drug monitoring. Therapeutic drug monitoring is important in the case of tacrolimus because tacrolimus bioavailability is 1 or 2%. So that is not about the dose. That is about the trough level. Means once we check the your blood level, suppose tacrolimus level is below this line, then there is a underdosing. There is no T cell effect. If it is more than trough level, then there is a effect. So whenever you are giving the tacrolimus, the dosing per kg body weight is not important. Important is the trough level. Suppose this is less than 3. So you have to increase the tacrolimus to get between 4 to 7. That is good response. And if you're getting more than 8, then there is a toxicity. So trough level is important while giving tacrolimus. Okay, this is one. Second thing, different drugs, because this tacrolimus, they are irreversible inhibitor of the cytochrome enzyme. So grapefruit juice, no, it's not grapes. Grapefruit juice, it's a citrus fruit. So they also inhibiting the same enzyme. So giving while taking tacrolimus, it is not advisable to take grapefruit juice or mixed fruit juice. So while not grapes, no, so because these drugs are inhibiting the this enzymes, cyclosporin enzymes. Then say calcineurin inhibitor, main SLE. Now it's a part of triple therapy in SLE, proliferative lupus, and for the class 5. Why in class 5 rapid proteinuria is there? Because it has an anti-proteinuric action. So calcineurin inhibitor can be used in the even class 5 also. In myositis, for myositis associated ILD, tacrolimus is advisable. In rheumatoid arthritis, cyclosporin, you can give cyclosporin. Tacrolimus, cyclosporin, especially cyclosporin in juvenile idiopathic arthritis, especially in macrophage activation syndrome. Uh, Behçet. In Behçet uveitis, you can use cyclosporin. But remember, Behçet, neuro-Behçet is a contraindicated for the cyclosporin because with calcium inhibitor because it can cause neurotoxicity. So this is there. Finally, I have completed my slides. Thank you. If you have any questions, please let me know. Hello.
Yeah. Hello.
Hello. Uh,
Hello.
it's complete, doctor.
Okay. Okay, sir. So thank you, Dr. Vish Prakash, for that really insightful session. And you have broke down the very such complex concepts into very simple and easy to understand language. So
Thank
we
you.
really appreciate your clarity and expertise on the topics.
Thank
So with this, sir, let me just check for the question and answers, like
you. Please.
if there are any questions. Uh, so there are few questions. We request you to give your insights for that.
Mhm.
Like, when do you prefer mycophenolate over azathioprine?
No, most of the chances in most rheumatological disease, that as I told you in while in my lecture, I told ki my MMF or mycophenolate mofetil is relatively specific for the lymphocyte and they have relatively less side effect. So as you know, autoimmune diseases is associated with lymphocytes. So we prefer mycophenolate mofetil over azathioprine in most of the cases, except ANCA vasculitis. ANCA vasculitis trials are showing favors towards the azathioprine. Otherwise, mycophenolate mofetil is most of the rheumatological condition wherever these two drugs are indicated. We prefer mycophenolate mofetil over azathioprine. But one indication where we use azathioprine, we can't use MMF, that is whenever patient wants pregnancy. Because I told mycophenolate mofetil is a teratogenic drug, azathioprine is not teratogenic drug. I think
Okay,
it.
okay. Thank you, sir. So there's one more question. Like, do you routinely check TPMT before starting azathioprine?
No, no, no. It's not like that because it's costly also. And in Indian setup, we are practicing in the Indian setup. So what we use, we gave azathioprine, then ask for it. Actually, it is advisable to check weekly blood counts and LFT, because suppose you have this TPMT deficiency, chances of toxicity is there. So patient will start developing cytopenias like anemia or other diseases. So once we give azathioprine, we used to check. We start from a very little dose. Then we check the CBC and LFT again and again. Once we are confirmed after 1 month or 2 months, now side effect is not happening, then we increases the dose of azathioprine. So while checking the blood counts, with your blood count and LFT reports, we can give azathioprine also without TPMT level checking.
Okay, okay, fine, sir. So one more question I'd like to, sir, put your insights, sir. Like, in diseases like lupus nephritis, what factors basically guide your preference between cyclophosphamide and mycophenolate as induction therapy?
Very good question, actually. But last guideline that cleared everything actually. We can use cyclophosphamide also, or we can first of all, I just want to convey one thing. I told you calcineurin inhibitor has an anti-proteinuric effect. Lupus nephritis means patient is losing protein, and patient is because of that protein and immune damage, kidney is damaging. So we have to stop the inflammation and we have to stop the leaking protein. To calcineurin inhibitor plus mycophenolate mofetil plus steroid. This is known as triple therapy. Okay. So usually what is recommended, we are using triple therapy for the LN. But suppose lupus nephritis patients come with very rapidly progressive renal failure and other systems also involved. We found it's very difficult to control because cyclophosphamide is most immunosuppressive drug, available immunosuppressive drugs. So we prefer cyclophosphamide if there is a very severe lupus nephritis. Otherwise, MMF plus CNI plus steroid that works good also. Two second thing is also there. MMF takes it for to create to start the immunosuppressive action of a MMF. We need approximately 1.5 months to 2 months. But cyclophosphamide starts showing its immunosuppressive action even within 2-3 weeks. So if suppose there is very rapidly deteriorating condition, then we prefer cyclophosphamide.
Okay. Fine, sir. Thanks a lot, sir. And if there are any more questions, please mention in the comments and we'll assist you with the doctor's response. So I think with this note, I think the session was quite enlightening. And Doctor, we are really eagerly waiting for your next, looking forward for your next session. And thank you for,
You
thank
Even
you,
I am
Doctor.
also eagerly waiting to present the next session also. That would be on the last Saturday of this month, and we will continue with our pharmacometallurgy series third. That I will cover the cytokine inhibitors. We will start biologics from now.
Great. So, to all the participants, we'll share the details very soon for the upcoming webinar details. So, once again, thank you all the participants. Thank you, Doctor. And thank you, everybody, for being a part of this session. And I think with this, we can close the session.
Oh, Namaskar. Okay, we can close the session. Thank you so much, Concard
Thank you,
team,
sir.
whole Concard team. I am so grateful to them. Thank you.
Thank you so much, sir. Bye, sir. Bye.